Good morning, everyone. Thank you for coming to our session on Illuminating the Closet, friends and coworkers and colleagues. We are going to go ahead and get started this morning. My name is Joel Moll. I'm from Virginia Commonwealth University, and this is Illuminating the Closet. Oops, so sorry. This is a little bit of a quick thinking thing. This will be interesting. No disclosures from anyone. All right, and here's our goals and objectives. I think we ran past who we are. I apologize for that. We're going to give ourselves a little bit of an introduction so that everybody can hear a little bit about our shared stories. The format, basically, we're hoping to have this a little bit interactive as well, but we just want to make sure we're trying to mix it up with different speakers and stuff to try to get going. So I won't belabor that point for everyone, but we're going to be talking about different things having to do with mentorship and giving some context to LGBTQIA plus learners. All right, and here's our shared stories. This is very sensitive, so Elliot, I think you're up first.
Hi guys, again, I'm Elliot Blum, and I'm coming from Emory, so just wanted to give a little background about myself. So in the top left corner, those are my maternal grandparents, and they're Holocaust survivors and left Germany in 1939, and they ended up escaping to Shanghai, because at that time Shanghai was accepting Jewish people. And they ended up getting married in Shanghai. You can see their marriage certificate in the bottom left is all in Chinese, and they moved to Chicago in 1946. And so they moved as immigrants and really didn't have any money when they moved to the United States. And they struggled, obviously, with anti-Semitism. And my mom was born about a year later after they moved to Chicago. And so my paternal grandfather is there also. He was also a Holocaust survivor and went back in and fought for the United States in World War II. And I just kind of wanted to just point out quickly about the struggles of my grandparents, because they had to struggle with adversity a lot, and it was passed down from generation to generation about the struggles that they had. And I was fortunate enough not to have the same struggles that they did. And just to qualify, I'm a hetero cis-normative male and cisgender male, and my struggles are at a minimum because of that. I don't have to come out every single day. And in this sphere, the biggest thing that I can do is be an ally. And I think that being an ally is one of the most important things you can do, as well as being an upstander. And so I think, just being sensitive to the struggles of my family, I'm kind of able to do that as well, and it's important to me. Whoops.
Hey everybody, my name's Russell. I'm a second-year resident at VCU with Dr. Moll. So I put up some photos of just kind of daily life. The two references are Boys Don't Cry was a specific movie I remember growing up. That kind of opened my outlook of this kind of topic and initially came to be making me more comfortable. The second is the It Gets Better project, and it's a great coming out nonprofit of providing resources of when the person is going through their coming out process, of making them feel more comfortable. And the others are just photos of me kind of hiking around and with my dog.
Good morning, everyone. My name is Melissa Edwards. I'm one of the second-year residents also at Virginia Commonwealth University with Dr. Moll and Russell. So I just shared a couple of things from my childhood into now. I actually identify as a lesbian female, and I came out about 3 to 4 years ago at this point, which was kind of like a monumental point in my life personally. But we do end up having to come out almost every single day, so I wanted to share the people that are most close to me and my biggest support system, which includes my co-residents, my family, my friends, and some of the things that they do to help me every day is just be there for me. And I also have my pet Calla there, and she chooses to be supportive when she wants to be, as most cats do. So.
Okay, good morning, everybody. I'm Michelle Law. I'm also from Emory. So I want to talk a little bit about passing and passing privilege. So in the green car there is my little tiny Peruvian grandmother who lived to 96. But I look white to most people. Sometimes if I'm really tan and wearing white, people think I'm brown. But mostly I'm white. But that affords me the privilege to pass. And some of you in this room may be familiar with that term, some of you may not. But it's really fascinating to hear what people will say when they don't recognize how you identify. So just a point there that sometimes for our colleagues who identify as sex and gender minorities, sometimes it is easier to pass. It's really hard to have to come out every day, all the time, to patients, to colleagues, to peers. So just something to keep in mind. And then I have Ryan White there, right? So I'm in my mid-40s. And when I went to school, it was a small school, lots of close-knit families, and a student 2 years older than me had hemophilia A. And he ended up dying from AIDS that he had received from a blood transfusion when he was in about the 3rd grade. But I find now that our learners and trainees, many people don't know who Ryan White is and how Ryan White and the Ryan White Foundation really changed the face of AIDS in this country and really started to reduce stigma. So it's important to remember Ryan White. Oh, sorry, Joel.
That's okay. It's a very sensitive clicker, so apologies for that. I don't know if there's another better way around it. But so again, I'm Joel Moll. I identify as a gay male. Pronouns are he, him, from Virginia Commonwealth University. And so I was born in the 60s, you know, the revolutionary free 60s, and then we went into the 70s and 80s. Early 80s is when I grew up, and of course that's when everybody was told that the Brady Bunch is the model family and Ronald Reagan was president. Sadly, that's also the time that we had the birth of the AIDS epidemic. So I grew up at a time that Mike Brady died of AIDS, so not so much the model family that was portrayed, I guess, maybe. And also we had the AIDS crisis during the formative years where I was both in medical school and trained as a medical resident, and sadly had some friends who died of AIDS and have some friends who continued to live with it. But things got better for a little while. We had some things going on. We had a lot of additional civil rights, marriage equality. I was able to marry my husband, who I've been with this year now 25 years. And then things now are getting a little worse, maybe a lot worse, depending on things that happen. So I think that context is really important because a lot of our learners and a lot of the people that you're going to be advising today have not been through some of these harder times. And they've seen some of the good parts, but now they're seeing some of the bad parts. And I think that's something that's really important to keep in mind when you hear all this over and over again about, you know, Florida and schools, not to pick on any particular state or whatever it is. You know, I think I saw this morning in the news feed that Mississippi had just made it a felony to provide gender-affirming therapy. So it's one of those things that, you know, your residents and your students are hearing this every single day, and how is that affecting their mental health? So equity, inclusion in medicine, this is one of my favorite slides of all time. The guy in the orange is Gabriel Martinez, who basically is one of our good friend's son, and this is his birthday party. I have permission to use this, but I love this picture because this always makes me think so hopeful about the future, because these kids all love Gabe and they all love cake, and that's about where it ends. Right? And that, obviously that's what should be ideal. But as we look at who we are as a bunch of, you know, especially that's dominated by straight white men who are taking care of a population that is not necessarily that, and certainly it includes that. And as we try to diversify our workforce, you know, it's something to kind of keep in mind that there are some changes, there's some differences. And so what is the reality? And even for somebody who identifies as a sexual gender minority, you have that reality versus what is equality versus what is equity. And I think that's so incredibly important. So I always add this slide in, and then obviously we'd like to someday be at liberation, but that may be a challenge right now. I mean, we have a divided nation. And we have a lot of cultural wars that are going on that for whatever reason have decided is politically, either from belief or just thinking that politically it's going to help them to go after the LGBTQI plus community. And again, I think it's really important to understand what your learners who so identify may be going through. But of course, it's not that simple. Sexual orientation is just one thing that makes up who people are. Gender identity is just one thing that makes up who people are. And there's a lot of intersectionality about that. And so there's a lot of cultural, a lot of internal conflicts in any one given individual person. And I think it's important to note that. The other thing that's important about a sexual or gender minority is one of these ducks is a little bit more fabulous than the rest, but you may not know who it is, right? So this can be very much a hidden minority that have the opportunity, as Dr. Law was talking about, passing privilege. And National Coming Out Day is every October. Pride Month is next month. But for somebody who identifies as LGBTQIA+, I'm going to continue to screw those acronyms up despite being part of it. Anyway, every day is National Coming Out Day. Every time somebody asks me, how's your wife? I pretty much, identify as somebody who's more cisgender than anything. But it's, if I had a nickel for some, I'd be retired, or I'd be like, on some nice vacation or something like that. No, and it just doesn't exist. So, sorry, this thing is bewitching us still. So I love this picture too. This is a picture of my residents from a few years ago. Half are gay, half are straight. They're in a gay kickball league. Nobody really knows who's who in this picture. You could make some guesses. You'd probably be wrong. But this is belonging. This is them all together, right? And so what we know about diversity, equity, inclusion is that's kind of where the panacea, so to speak, this is the high point, is you want your residents to belong. Because if you have, some scattered gay people, if you have some scattered whatever, but they really have that wall between everyone else and them, they're not belonging, and quite frankly, we failed.
So I think in considering LGBTQIA learners in medicine, it's helpful to consider the background and climate of our current country. And much of what we do know is what we don't, and that is exactly how many people identify as lesbian, gay, bisexual, transgender, or anything else. But this is an estimate from a Gallup poll of February from this year, where the most recent data shows us that around 7.1% of people in the United States identify as LGBTQIA+, with the biggest increase specifically being in those that identify as bisexual. I think something important from this slide to note is that back in 2012, the question was specifically posed as, do you personally identify as lesbian, gay, bisexual, or transgender? Whereas Gallup has now changed this to, which of the following do you consider yourself to be? I'm hoping that this is likely a way that a more inclusive way of asking this question, and you're also able to select more than one that may apply to yourself. Bearing that in mind, this is kind of the breakdown in terms of who identifies as LGBTQ in the US, and the percentages of which. If you'll notice on the left, the percentages do not add up again to 100%, as you're able to choose more than one category that you may find yourself belonging in. But still, if you notice on the right, this is a very small minority of the United States population. This is even more so difficult to quantify, as we can see that sexual identity, and the caveat being sexual identity is not always the same as sexual activity. This is actually data from the NIH back in 2020, where the estimates are a little bit different in terms of they estimated 4% of LGBTQI plus identify as such, whereas even more percentage report either same-sex behavior or some degree of same-sex attraction. So even if you are identifying those things about yourself, you may not actually find yourself identifying in the LGBTQI population. I think this figure kind of quickly summates this point, is that what we do know is that biologic sex is not equivalent to your gender identity or how you think about yourself, and how you choose to express your gender, who you're attracted to, are not all the same. And this is even more so that a person's individuality is really a continuum, and you can fall anywhere on the spectrum of any one of these different concepts. When it comes to growing up LGBTQIA+ in America, there are very different concerns whether you find yourself being LGBT or non. And this is from a Human Rights Campaign survey of about 10,000 plus youth aged 13 to 17. And if you see on the left, the most concerning concerns that LGBTQ youth identify with is surrounding support, either at school or with their families, and how being out or open can really affect those relationships. Whereas non-LGBTQ youth are more concerned with advancement in school, to college, career, or finances. Additionally, Gleason published a school climate survey in 2019 that indicates even further consequence of hostile school climates. Students that endure higher rates of victimization due to their sexual orientation are 3 times more likely to miss school in a given month, have lower GPAs, twice as likely to be disciplined, have lower self-esteem, and twice as less likely to go on to secondary education, which certainly trickles down into pursuing medical education. In considering the journey to becoming an emergency medicine physician, we know that there is a lot of training involved and a lot of steps in which to do so. But I think it's important to also think of that at any level of training, you're prone to stressors not only in your professional life, but in your personal life as well. But we like to think of this as that all those many stages and years where proper education can occur, and there's hopefully areas in which we are able to intervene at these levels. Now that we've kind of seen the national demographics and those who identify as LGBTQIA+, this is data from the AAMC in terms of medical student demographics. As you notice on the right in the highlighted numbers, this is data from 2020, where the number of respondents has actually steadily increased each year. The largest increase, again, being those that identify as bisexual. We're hopeful that the increasing number of respondents signifies greater and increasing comfort in sharing one's personal identity. However, when it comes to sharing one's personal identity, this is something that even today we can find is very difficult. This is a survey from 2015 in which they found that close to 30% of sexual minorities choose to conceal their identity, whereas 60% of gender minorities actually end up concealing their identity, with the most common reasons being fear of discrimination, lack of support, social or cultural norms, or it's that nobody's business, which presumably would be less of an issue if creating a culture of acceptance were more the norm. Additionally, an academic medicine journal article from 2005 cites even more concerns of medical students disclosing their sexual identity from fear of rejection of peers or faculty, even in concerns of not being able to obtain a letter of recommendation. The medical students that were in this survey, they said on their medical school application, 95% chose not to disclose their identity as they felt that it was irrelevant, they were uncomfortable disclosing, or they were concerned that they would not be accepted. When those same medical students were asked about whether they would choose to disclose on their residency application, 52% were unsure about disclosing, 33% planned to disclose their sexual orientation, but that was basically surrounding if they thought that the program they were interviewing at would be accepting of them. 15% did not plan to disclose, with a large portion concerned that they would not be accepted. When you notice concerns of sharing identity, it must be considered that LGBTQ students are less likely or more likely to experience a degree of bias even from peers. In a study of heterosexual first-year students in medical schools across the United States, nearly half of the respondents expressed at least some explicit bias, and 81% exhibited at least some implicit bias against gay and lesbian individuals. This was also referenced in a systematic review from 2019 in BMC Medical Education, where they identified 640 abstracts addressing bias among healthcare providers. 60 of those studies identified medical education programs to reduce bias, and what was found, that bias-focused interventions are effective. Experiential learning and intergroup contact are helpful in decreasing explicit bias specifically. I think this proves the point that education along any point in the years and wherever it is on that stage or continuum in becoming a physician can make a difference. This is important additionally as we are now collecting data with an emergency medicine residency specifically. Back in 2020, ABEM at the end of the in-training exam started to collect survey data on who identifies as a sexual minority, with the most recent data showing that 6.3% of our emergency medicine residents identify as LGBTQIA+. Why is this important? Well, perceived acceptance of sexual and gender minorities may actually influence your specialty choice. This is a survey of 2,800 individuals, and based on this survey, it was reported that perceived minority inclusivity was inversely related to specialty prestige. How they defined specialty prestige was utilizing median income and available residency positions per U.S. applicants. So if you think of things like neurosurgery, plastic surgery, or anything else along that degree. whereas factors influencing specialty choice are things such as exposure to minority faculty while in medical school and the respondent's later specialty. Additional stressors in residency can also present as hiding one's personal life. This is a study of surgical residents, and in generalized statements ranging from "I feel happy at work" to "I feel comfortable openly discussing my partner with fellow residents," the largest discrepancy that you can see exists in the disagreement statements, essentially meaning that people don't feel comfortable in sharing anything about their partner or bringing a partner to a surgical event. Presumably, heterosexual people do not have this worry. In additional data from the same study, more than 50% of people surveyed did not feel comfortable disclosing their identity to attendings or even their co-residents, and that was due to fear of poor evaluation or that feeling that they would not belong. When you think of the minority stress model, we can think of the general stressors that face the population, whereas if you are a minority, you have increased stress due to internalized homophobia, identity concealment, general stressors from circumstances and environment. And it's no surprise that when you put all these things together, people are more prone to mental health and substance use issues if you identify as a sexual minority. We can actually see this data in the Substance Abuse and Mental Health Services Administration data from 2019, where 1 in 2 LGBTQI plus adults were found to have struggled with illicit drugs, 3 in 5 struggled with alcohol use, and 2 in 5 were actually having a serious mental illness. Together, about 7.6 million LGBTQI adults aged greater than 18 were struggling with either a substance or a mental health disorder.
So moving on to the challenges and barriers of LGBTQ colleagues. So we'll kind of go through an outline of lack of education, limited data, discrimination, harassment, lack of support, employment concerns, and then health risk. So to start with lack of education, so the extent of LGBTQ education that medical students received in a 2011 study found that the median time spent was a total of 5 hours. So within their 4 years of medical education, they received only 5 hours. And was surveyed that some didn't receive any medication or any education at all. So one of the biggest organizations that studies or surveys these queer colleagues is the GMLA. And so they've done 2 big studies, the first one in 1994. And these are the percentages they found, that 34 were being verbally harassed at work, 37 were being ostracized, and 88% had heard disparaging remarks regarding one of their fellow patients. The second study was in 2011 and further confirmed that 15% have been harassed, 34 were being witnessed with discriminatory treatments of their patients, and 36 had witnessed disrespect from their actual family members. And so this kind of leads to residency discrimination. That the most recent study by actually Dr. Law in 2001 had surveyed 483 residents, and about half of them had heard discriminatory remarks from patients or patients' family, and 13 were actually from their colleagues. And it was remarkable that they were 2 times more likely to have suicidal thoughts compared to the other residents. So this not only applies to their fellow residents, but can trickle down to their patients as well, that discrimination translates into the patients that we're actually taking care of. And then it leads down to the learners in our work setting, that 41% of medical students reported anti-LGBTQ jokes, and and I guess remarkably, that lesbians physicians were 4 times more likely to report harassment compared to their heterosexual female physicians. So kind of transitioning into the harassment, so I think we have to kind of clarify the definition of discrimination versus harassment. That discrimination occurs when an employer treats certain members of a certain class unfairly, where harassment involves acts targeted toward actually one person. So in this recent study by Elise in 2011, came up with percentages. About 10% were actually denied referrals from their fellow physicians. 15% were being harassed by their colleagues. 22 were being socially ostracized, and 27 were hearing discriminatory treatments of their coworkers. And the percentages keep going. Of 34% were witnessed discriminatory care, 36 were disrespect toward their patients and partners, and then 65 had heard derogatory comments. So while discrimination can happen to all kind of social minorities, and it feels as if harassment is something that we can't control, I feel like lack of support and mentoring is something that we can change. So it's nice to have allies like in the room with us, that if you're wondering what you can do, in addition of just being here and being open to this conversation and educating yourself, I think the one thing that we all plead for is if you see something in your workplace is to speak up. That if you see it, you speak up. So these are personal accounts. The first one from a gay medical student advocating for a mentor of his fellow LGBTQ peer during the process of coming out. And during that process is very sensitive and to be vigilant about their professionalism. The second is an account of a lesbian dental student, and she's stating to just be comfortable with these conversations and be open to them. Another kind of challenge and barrier that our queer colleagues that have to deal with is kind of disclosure. And disclosure of during your medical student application and during your residency application. That they surveyed in 2005 with MeChant, about 95% did not disclose on their medical school application. They felt it was irrelevant, they were uncomfortable or concerned that they actually wouldn't be accepted to the medical school. And then during the residency application too, that 52% were unsure if they should disclose, 33% planned that they would disclose and actually didn't. And a large proportion of them planned to disclose the programs, but they felt like the environment was uncomfortable for themselves. And this translates into kind of employment concerns as well, that if you're feeling that you can't disclose on your actual medical school or residency application, that you wouldn't do it in your job setting as well. So this is actually a recent graph of from light blue to dark blue. Light blue is stating that they do have certain laws that prohibit discrimination against public employment based on sexual orientation only. The dark blue is prohibit discrimination based on sexual orientation and gender identity. And then the black label is there is no such required laws. And you'll notice that the state we're in today is labeled black. And lastly, it's kind of health concerns that LGBTQ patients are at increased risk for cancer, mental health disorders, substance abuse, and STIs. And data shows that these individuals receive poor health care and often is considered because of the discrimination that they encounter. And so instead of ending on a bad note, I'd rather end on kind of more uplifting tone and about the resilience of this community. And in spite of the difficulties related to coming out in the workplace, again and again, this community has shown that they're resilient. And they've been noted that this is their better response in stress. The vast majority of respondents engaged in healthy stress strategies, becoming advocates and educators in this workplace, like the people sitting next to me, and engaging in positive self-care activities. And I'd argue that that's what makes us better emergency medicine physicians.
So we're going to go through some cases right now, just to kind of display some of the themes we've been talking about, and we have some opportunity for anybody to join in with some shared experiences if you are interested or want to share. So this case is about your extroverted star second-year resident. You notice that they have a dive in their in-training exam. There's complaints from faculty and patients. They just start not coming to social activities for the residents, and they're late to work. And so you start to see some issues with their performance, and they were, your star second-year resident. And so then you go and meet with them, and they tearfully disclose to you that they might be gay. And so coming out is deeply personal. There's varied factors that affect the decision, and it never ends. And so you have one of your star residents who's going through a personal dilemma, and it's difficult for them, and you can see that it translates into the working environment. And so I just kind of wanted to go around the room to see if anybody had experiences like this personally with colleagues or peers, where they noticed that, or they felt personally that they were struggling internally, especially with identity concealment, and that was translating into the work environment. And how did you deal with this on a personal level, or how did you deal with this with colleagues or residents that you were working with?
If you raise your hand, I will come with Mike. Anyone? Or gender identity, either way? All right, awesome, thank you.
Hi, so I'm a program director and a resident who was, it was beginning of his second year, decided to come out, and he had moved his wife and child to across the country. His wife was not supportive of that and took his child back across the country, and so he subsequently had some struggles that were apparent just before he came out, and then after that. And I'm here because as a program director, I really don't think I had the tools to support him as he needed. I tried as best I can, but I don't have enough tools in my toolkit, I think. And so, and I know that the answer is, like how do I be a better, ally and supporter as a program director is surely a complex answer to that, and you can't give me the recipe for that. But I struggle with that personally, as he did as well.
I think the important thing is obviously to let him have some control over that, in the sense that, sometimes people will feel, especially with children, let's rip the Band-Aid off and tell the parents and just get it out in the open, and that's obviously damaging. So, you just have to kind of let that do and support and know they're in a no judgment zone. I think that's the thing that matters, because people, when they come out, at least from my personal experience, and certainly we can have the panel chip in, but, you worry about, are you going to be rejected? Right? And you assume you're going to be rejected, although the vast majority of our coming out stories are actually positive, but there are certainly awful ones out there. And that's what you hear about, and that's what you worry. So just that reaffirmation and support, I think, is the best thing you can do as a program director or leader. And then sometimes, maybe you can hook them up with somebody who can be a mentor for them, to kind of make their way through the process and what it's like to be gay in medicine. So, Russ, Melissa, any other additional comments?
Hi, I'm a program director, and our program has been traditionally very friendly to the LGBTQIA+ community, and so I found this surprising. About 10 years ago, I had a resident who was in the military, was Catholic, and struggled throughout residency with interpersonal relationships with colleagues, and really was just one of my more difficult residents. And it wasn't until this person graduated that we I saw them again in follow-up, that this person was struggling with coming out, and had a very happy life afterward, found a spouse, and was doing very, very well. And it was a complete personality change, and it just wasn't on my radar, because I felt like our program is so friendly, like, of course this person should come out and be, feel great, but it really was more of the the religious and the military kind of background that made this person reluctant to do so.
Yeah, so the intersectionality, I mean, that's so incredibly important because you can convince yourself of anything, right? And if you're in the military, I'm going to be rejected. I'm going to be rejected by my family because they're very religious. That happens all the time. I mean, I grew up in a conservative family, had the same thing. I think a lot of us had that experience. Do you guys want to add anything?
I think something that, for me personally, I chose to see residency as a clean slate. Because of having not come out, until 3 to 4 years ago, most of my relationships had kind of lived in privacy for much of that time. And so residency I saw as like a new opportunity to share who I truly am, and I think that was actually a very helpful thing to me. I still can't really even complain because I have the world's most supportive family, and I think still that there was like this 2% chance in my brain that if I told them that I was gay, that maybe they wouldn't accept me. And so I think that's like the biggest barrier, at least for me, from coming out. Not that I really assumed that I had lack of support, but there's just always that chance. And so I think if you are extending sort of any kind of mentorship or just showing people that they do have that support network, hopefully they'll, at one point or another will end up coming out.
Yeah, and if your parents are helping you with medical school, you don't want to come out, right? I mean, who's going to pay for medical school, from that standpoint?
I don't know that I have many tools to offer you, but a couple of comments I would like to make. Breaking up with a wife and losing easy access to your children is terribly stressful for any parent or husband, whether that husband wants a husband or still have the same wife. You're still a parent, and you will be a parent to those children forever, regardless of adding on top of it the stress of being, of thinking about coming out. And I think the first thing you need to do is to reassure them on a professional level, since you're the professional organization that he is currently in, and to say, I will not allow any negative comments about your potential orientation or your current orientation or what you have been or whatever to affect in any way our letters of recommendation or go on whatever, and speak most sharply to any colleagues that seem to display any sort of negative bias towards this guy, and make sure he knows it. That would be one thing. So take care of the professional. That's your primary place. See if you can smooth his way on various rotations. If you know what the attitudes of the places he's going to rotate, and discuss it with him. The surgical rotation at such and such has a reputation of this, and there's this other one. It may not be as good, but you'd probably be more comfortable there. Which one do you want to take? Give him the choice. And then there is probably some kind of an EAP in your organization, Employee Assistance Program, where you can get counseling, because having some place to spew is often useful. You may or may not have any out LGBT, et cetera, because I can't say all of those letters. Colleagues in your department or other departments that you know of, make a connection. Those are some tools that I would recommend, specific things. Thank you, Joel.
All right, I think you have time for one more comment. There was I thought I saw a hand up, maybe. No? All right. Michelle.
All right, so we will move to the next case, and then I think we'll be able to talk a little bit more as we sum things up about, some things that you can put in your toolkit and how we can just recognize that for peers, students, residents who are hearing comments like this, it goes much beyond the comment itself, or it goes beyond just coming out, right? This is a very complex and multi-layered situation for many. So Tim is rotating in emergency medicine, his chosen specialty. We ask him to put an IV in Mr. Smith. Outside the room, the nurse asks Tim what he and his boyfriend did last weekend. He enters the room, and Mr. Smith says, "I don't want a faggot to touch me." So what would you do? You're the attending who just heard this. You're the attending who's evaluating Tim, and you're also the attending who just told him to go put in this IV. What does this look like? What do you do?
Who's had this? All right. So I'm sorry, I don't mean to put you on the spot. Are you willing to share what you did?
So I work clinically in Dundalk, Maryland, which is a hotspot on all of the people who map these things about gender violence, even though it's in Maryland, which is historically a blue state. This scenario and this scenario with gender nonconforming trainees is routine, and I work as a nocturnist when everyone's a little more disinhibited, is a routine portion of what I end up having to supervise as a clerkship director. I think that the thing that I like more in this scenario is that it happened in my earshot, so I get the ability to intervene. What I worry about a lot is when this doesn't happen in my earshot and when I don't know if my trainee is going to be brave enough to come and tell me that they're in a situation that's really deep water, because this is a deep water situation in my feeling. For me, I think that a lot of the evidence-based strategies that are about being an upstander in situations where our patients evince racial bias and make comments that use derogatory and harmful language around racial bias and around trainees that are visually racialized to our patients allow us a lot of opportunity to approach these kinds of situations. It's as the boss in the emergency department, often we have a lot more power than we recognize. I am not necessarily visibly queer, although I take steps to help make sure that my trainees know that I am, but I still have the ability to be like, that language isn't acceptable, no matter how sick you are. We're happy to care for you, but you can't abuse our staff. I'm going to give you a second to cool off, and I'm going to take my trainees and my staff with me. We'll be back in just a moment, assuming that this is a patient that's not so critically ill that 30 seconds can't wait. And then often I'll take my trainee and do a check-in with them. Sometimes they're going to be so overwhelmed with the adrenaline of the moment that now's not a good time for practicing a procedural skill. Their hands are shaky, they're sweaty, I want them to be able to perform their best in front of me, and I want to reassure them that it's okay if now's the moment that they can't perform their best, the same way that it would be if they had low blood sugar in that moment or something else. But I probably talked way too much. I'll let somebody else. I saw a couple other hands.
So you made
That's all very good.
an excellent point about checking in with the trainee, right? So I think we all work really hard to be allies and to be upstanders, but it's really the person who was the victim of the microaggression, the transphobia, the macroaggression, whatever it is, the ball is in their court, right? So it's really important to check in with that person. And you may say, I would like to do this. Is it okay if I do that, right? If you want to use that language because you think this is a moment to educate the patient and to validate the trainee, but it's also okay for them to say, I don't want to go through that today, because how many times have they already been through it? So I think, we have to be just cognizant that even though we are well-intentioned, it might not be the day or the time to do it. And I think you made that point very well, so thank you.
Yeah, and I also add that, remember other people that may have been in earshot, right? Because maybe the nurse identifies in the LGBTQIA plus spectrum, maybe they have a brother or sister or somebody like that. So, there's multiple things that, can happen on that. So but setting that expectation, and I think modeling the values, I think, as a department goes a long way as well. Not only state them clearly from the very beginning, which is what we try to do, but then reinforce them and put your actions where your words are. Other comments? I think they were, yeah.
My department has historically been extremely supportive of framing this kind of language as abusive. So this kind of language is abuse. It's abuse in the same way that hitting your healthcare provider is abusive. And I'm lucky to work in a department that has had strategies around this, and we need strategies around this because many of our patients choose to be abusive when they come to seek emergency medical care, but that it doesn't have to be tolerated the same way that physical workplace violence doesn't have to be tolerated.
Absolutely, and it's important to call it what it is, right? That's not a microaggression, that's homophobia, right? I mean, if you're gonna put a label on it, use the right one, right? Don't diminish the experience. And I do think we are starting to see in healthcare, more hospitals and healthcare systems that have patient codes of conduct and other things that, we may be able to use to our advantage. But those aren't ubiquitous yet, but you're absolutely correct. It is abuse. It is verbal abuse.
Any other comments?
I think also ER is kind of an interesting specialty of the patients don't choose us, right? Like we choose them. And so when they walk into the room, they don't know what they're getting. And we've shared multiple encounters together. As our kind of department is all collectively wear rainbow badges when you walk in the room. And I've had multiple patients tell me, I don't want you to be my physician. And it's nice to have those attendings of, we hear your opinions, we won't accept that, how can we help you?
We probably have to finish.
Please, very quick. We want to make sure we finish on time. No, go ahead.
Thank you. Thanks everyone for sharing. I appreciate it. So we're just going to go over best practices quickly. This is just a summary, and then we'll let you guys go, hopefully maybe a minute late. So first and foremost, before you implement any of this stuff that we've talked about today, you need to assess your climate, right? Because it's important to understand what you can do at your institution. Some of these things are fairly easy to implement, but based on the climate, based on where you're at, some of the things we spoke about today will require more of a deliberate plan. So it's always important just to know where you're at, especially at your institution. So how do you optimize your climate? Creating an inclusive climate is important. So diversity is a stated value, and diversity is visible. And like we spoke about, microaggression or homophobia is not tolerated. Education, as we spoke about before, especially through intergroup contact and experiences, can improve this, especially with your residents and medical students and your faculty. Identifying mentors and allies, and being able to anticipate conflicts and be able to talk about this with your department before stuff like this can occur. So talking just about visibility for a second, which is obviously very essential. Having policies in your department, having stuff on the wall, social media presence is very important. Having a diversity webpage, having an LGBTQIA section, and also just being able to have this presence, making sure that it's known. And like we said before, abuse is absolutely not tolerated, and making sure that that's visible. Dr. Moll did a survey in 2020, which was for the residency program directors, which showed 69% new LGBTQ faculty and 81% new LGBTQ residents. We also found out that with medical trainees, like we said before, who have less contact, are more likely to express anti-SM attitudes and have explicit biases. So, visibility, contact, education are all really important things to mitigate this. And then how to develop and deliver an inclusive curriculum. So there's 3 themes that are really, really important. And I think, again, this goes back to education. So having this can help with explicit bias to some degree. And so having inclusive language, role models and allies, and having visible contents, as we just spoke about. And then there are 3 levels of types of inclusivity. And so this is kind of 3 levels of different education curriculums you can implement. And so the basic one is just awareness. So having awareness that there's different sexual and gender diversity and identities, and just avoidance of abusive language. So that's basically on the lowest level, which is probably the easiest to implement. And then there's additive, which is having topics, themes, and readings for your faculty and residents that are about LGBTQ identities. Also having access to mentors and avoiding hetero and cis-normative language, which is pretty important as well. And then kind of the highest level, just the most important and the best way that you can have inclusivity would be kind of transformative, which is just really a critical approach to learning, where you can have a critical approach to language, engagement with trans and queer inclusive language, which is really important. Not just avoidance of abusive language, but having inclusive of this language, and then not only having access to mentors, but having role models, having allies in the teaching and learning environment, which is really important as well. And so mentorship, like we said, is essential for academic success and may be difficult to find. So you might not have somebody who can be a mentor at your institution. So maybe you don't have a strong ally, maybe you don't have a strong LGBTQIA faculty that can serve as mentor. But you can look nationally, right? We have an SAEM LGBTQ committee, there's ADIEM, there's word of mouth of friends at other institutions, and so it would be the best possible scenario if we can get a mentor at everyone's institution. But if that's not the case, there are mentors out there, and it just needs to be connected. And I think the ADIEM LGBTQ committee and group, I think, is a very good place to start. And again, mentors are obviously very important to trainees. And so, just caution for unconscious bias and the term, what is fit for our program, and it's just not great terminology to use because it can marginalize people. And then again, do I belong at this program, right? If your program is all, the pieces on the left, the chess pieces on the left, or whatever these pieces are. If it's on the left and you're coming looking at a program and you're on the right side, do you really want to be at this program? Probably not, right? And so this is just a great quote, and I will close with this. It's a Harvey Milk quote. So it takes no compromise to give people their rights. It takes no money to respect the individual. It takes no political deal to give people freedom. It takes no survey to remove repression. And that is it. If there's any questions or comments, we'll open it up to the group. These are our contact information if anybody wants to contact us. Again, if you're looking for mentorship, we would be able to help out or at least point you in the right direction. And so this is our information. I'll leave it up there for the remainder. And then again, sorry for going a couple minutes over, but I appreciate everyone being here today. I appreciate you spending your time with us to speak about a really important topic.
Thanks, everybody.